Today we'll look into various X-rays which you may or you may not get in your exam, in your table vivas. Am I audible to you all? Okay, so now you have to identify the X-ray. So I'll ask you one by one. So maybe we'll go group by group. So all those who are from group 1, anyone can, anyone who wants to answer, he or she can unmute herself or himself and they can say what do you see in the X-ray. So I think group 1 from roll number 1 to 25 I think. So anyone from group 1, roll number 1 to 25 who wants to answer? If I won't get any volunteer, then I'll specifically ask roll number. Now I am giving you choice. Anyone from group 1 can answer. What do you see in X-ray? So no one. No, this is not Montegia fracture. Somebody has written Montegia fracture in chat. Okay, Colles fracture. So what is Colles fracture? Can anyone define what is Colles fracture? You have option for unmuting yourself and answering the question. So anyone who wants to try, who wants to speak, they can unmute themselves and answer the question.
The fracture is the radius at its cortical junction.
Okay, very good. Fracture of distal end of radius at the corticocancellous junction, which is roughly around 2 centimeter or 1 inch from the articular surface. So why do we call it Colles fracture? Why we say it's Colles fracture? Where come the word, from where Colles came? Is it some place or some person? Why we are calling
Sure, because it was described by Abraham Colles.
Which Colles?
Abraham Colles.
Okay, that's right. This fracture was first described by Abraham Colles in around I think 1914. So it is called as Colles fracture. So what is the special characteristic about this fracture? I mean to say, what can be the displacements in this fracture? Different displacements. There are six types of
dorsal shape.
Okay, dorsal tail, dorsal shaft.
Okay, this is fragment. And also
So lateral tilt and lateral displacement also.
Okay, two more.
So reduction of fragments and supination.
Okay, very good. Six displacement: lateral shift, lateral displacement, dorsal displacement, supination, and impaction. So, what is the most common complication you will see in Colles fracture? Dinner fork deformity. Okay, it is one of the that is, deformity is not a complication.
so
Finger stiffness. What else? Malunion. What else? Carpal tunnel syndrome.
Complex sleep pain syndrome.
CRPS. Okay.
The rupture of EPL.
Okay. So first of all, if you are asked in exam, you are shown this X-ray, how you will start? You should not say that directly that it's Colles fracture. How you will answer the? How you will describe the X-ray? You have to describe the X-ray first. Like you will say it is. You can say it's a digital X-ray. Earlier we had plain X-rays, manual X-rays. So they used to call it was plain X-ray, but now you can say it's digital X-ray of wrist. If you can see the side, if it's written, you can say left or right wrist. Both AP and lateral view, we are seeing two views. So in this way, first you have to describe the X-ray, what you will overall what you are seeing in the X-ray. Okay, then you will say, and we can see there is a fracture at the lower end of radius or distal part of distal end of radius, and we call it Colles fracture. What is the opposite of Colles fracture? What is it opposite counterpart? Smith fracture. What are the other fractures you get in distal and radius? Okay. Smith, Barton, and what else?
Shock
Fractures. Okay. Okay, so these are okay. So these were all some of the questions which you can be asked if you are shown this X-ray of Colles fracture, regarding Colles fracture, and yet all the related questions you may be asked in your table vivas. Okay, so we'll move to next X-ray quickly. So now as I explained you in earlier X-ray, now you have to start from the very beginning and you have to describe the X-ray first. So what do you see in X-ray? Now I will go to second group from 26 to 50. Anyone from 26 to 50? If someone is not answering from 25 to 50, it will be open for all. Anyone can, you can wait a little and then anyone can answer. Okay. Someone has written fat pad sign, but of course you can see the fat pad sign, but what you are seeing in x-ray, you have to describe everything from first. Which view is this, which part of the body this x-ray depicts, which is the view, what is the view, whether it is anteroposterior view, whether it is oblique view, or whether it is lateral view. So you start from there. Who is going to speak? Okay, I'll arbitrarily call some roll number and you try to speak. Okay. So 32. Who is 32? Is he or she present? Roll number 32. Is it audible to you all? Because I'm not getting any response. So who is 32? See, this is more of an interactive class, so it won't be like I'll be saying and you will only be hearing. So some input I should get from you, and then I will also discuss other things. But it won't be like I will be keeping on saying and you will be keeping quiet. So somebody has to answer. There is an option of unmuting yourself. You can unmute then you can answer. Texting doesn't always serve the purpose, because in exam you have to speak. There is very much difference between speaking and writing. So in a way you will be getting little bit of confidence once you start speaking here. Next time it will be more better. You can say it before your examiner or before external. So it will be just like a practice for you.
So it is a lateral view, X-ray showing supracondylar humerus fracture.
Lateral view of what?
The elbow.
Of elbow joint, showing supracondylar humerus fracture.
Humerus fracture.
Okay. So here we can see there is a fracture. So which type of supracondylar fracture is it? There is classification for supracondylar humerus fracture.
So this is type 2.
Type 2. Okay, why do you say type 2?
So because type 2 is an incomplete type of fracture, and here the fracture line does not cross both the cortex.
Okay, so you mean to say the posterior cortex is intact in this type 2. You are very much correct. Some of you are writing type 1 fracture, but actually it's a type 2 fracture. When the posterior cortex is intact, you say Gartland type 2. In type 1 there is undisplaced fracture. There won't be any displacement, but here you can see slight amount of displacement in its anterior cortex, and the posterior cortex is intact. There is no breach in the cortex, so you can say that this is type 2 Gartland classification. रेज हैंड का तो ऑप्शन
देखिए चार्ट में देखिए तो
ये
रेस आया क्या नहीं आया इसमें नहीं आया
इसमें यहाँ पे देखना
चैट
ये
बड़ा करना पड़ेगा वहाँ से देखिए
ये ये
हाँ बड़ा
नहीं तो वो अनम्यूट करके आंसर दे सकते हैं ना.
कर सकते हैं, लेकिन जो भी हम यूज करेंगे ना और अपना नाम और नंबर बता के फिर आंसर करेंगे.
नहीं ठीक है, नाम वगैरह तो आ जा रहा है. So type 2 we are having Gartland classification. So what are the signs and symptoms you will get in supracondylar humerus fracture? What is the deformity you find in supracondylar humerus fracture? Gunstock deformity. Okay. But that usually it comes in complication. But I am saying about how you clinically, when you see a patient with supracondylar humerus fracture, what do you find? You don't find gunstock deformity in acute cases. Suppose a patient comes with supracondylar humerus fracture, you won't see a gunstock deformity. Gunstock deformity is a sort of complication you get after you have malunion and you get gunstock deformity. But in acute cases, you won't get gunstock deformity. So what is the deformity or the clinical sign and symptoms you get in supracondylar humerus? There is some other deformity.
So pain, swelling at the elbow joint, and S-shaped deformity.
S-shaped deformity, you get S-shaped deformity. And what are the signs you will find in your radiological assessment? If you see X-rays, what are the signs? Number one, you can see the fracture clearly. What are the signs you can see, or you can extract from this X-ray? Someone had written earlier fat pad sign. Yes, else you can see the fat pad side? What else you can see?
Unusual posterior prominence of the point typical
So whenever you are yes,
Dimple sign.
which sign?
Dimple sign, sir.
Dimple sign.
Sir.
So dimple sign, do you find it in X-ray?
No, sir. Clinically, you see, sir.
Clinically you can find dimple sign, or even you can appreciate in X-ray sometimes when you can see this is a soft tissue shadow. So when this anterior fragment, it will impinge through this shadow, soft tissue shadow. You can also appreciate in X-ray, as well as clinically also you can see the skin puckering sign. You can see there. Okay, what else you can see?
crescent sign.
Okay, crescent sign. What else? There is a line which you can make from this anterior cortex straight down. Anterior humeral line. It usually passes from the capitulum, anterior 1/3 and posterior 2/3. So it must pass through this part. But as you can see, this is slightly displayed forward. So this line will not pass through capitulum. It will pass straight in front of it. So what is 3-point bone relationship? What is the significance of 3-point bony relationship in supracondylar humerus fracture?
Sir, 3-point bone relationship with intact supracondylar humerus fracture.
It is formed by which 3 points?
Sir, it is formed by medial epicondyle,
So medial and lateral epicondyle and follicrum. So as we are getting fracture superior to it, so this relationship is maintained in supracondylar, whereas it is disturbed in elbow dislocation. Okay. So what are the complications of supracondylar humerus fracture? Most important?
So Volkmann's cone fracture.
VIC, yes, you can get. What are others? So always, whenever you are asked about complications, you should say things which are most common. So try to say the most common thing, not that I will say which is least common thing. I will say the first. The complication deformity, otherwise we call it gunstock deformity. What else? Myositis ossificum. So this cubitus varus deformity, why we are getting that deformity? What is the primary cause of the deformity? Deformity is what we see, but what is the pathology, or what is the disturbance that we are getting in the bone? So it is manifested as gunstock deformity. Yes, it is due to malunion. The bone has not united properly. It has united in a different position or a different angulation. So we get a gunstock deformity. Okay. So then we'll go to next X-ray. So now first I'll give from 50 to 75, and one who is anyone who wants to answer. What do you see in this X-ray?
बिल्कुल मैंने एक देहाती करके जाता था मत करने में बहुत नाम किया इस सब को हटाया जैसे ये ऊपर नीचे जो दीवार डाला हुआ है इसको प्लेन करके प्लेन में बनने के लिए लोकेशन ऊपर ये इस टाइप से निकाल दिया
Somebody who is doing personal talking, they can mute themselves, and if you are unmuting, then you should say the answer. So 56 happened to be my roll number in first year MBBS. So if 56 can try to answer. Who is 56? Or if you don't want to answer, you can say pass, or you can transfer to someone else. Just you can make faster so that we can cover all the x-rays. You need not, if you know, you can answer. If you don't know, someone who knows or someone who wants to try, they can pick. Yes? No one?
Sir, this looks like pathological fracture. I'm not confirmed with this.
First of all, I said you should describe a X-ray. What you are seeing? You are seeing two bones. Which are the two bones?
Sir,
Radius ulna. So you can. It's a radiographic view, or it's an X-ray showing radius and ulna.
Yes, sir.
So what makes you think it's a pathological fracture? Where do you see a fracture?
Sir, there is some underlying disease, osteomyelitis.
Okay, there may be some underlying disease like osteomyelitis, but where clearly can you find any break in continuity of bone? Like you are saying, it's a fracture. What is a fracture? A fracture is something when there is a break in continuity of bone. So your in radius will come concentrate. Of course, we can see that something is there in radius. So in radius, just you try to find out where do you see any fracture line.
No, sir.
So there is no fracture in this, but you can say that there is an underlying disease. So possibly, what is this underlying disease?
Sir, osteomyelitis.
Chronic osteomyelitis. Osteomyelitis, you have to mention that you don't get something like this in acute osteomyelitis. You should in orthopedic asked about X. If you are shown something in X-ray, you think in osteomyelitis, you should say it's a chronic osteomyelitis. Okay, so it's a chronic osteomyelitis of radius. So what are the features which will help you to support your diagnosis? What you can see from the X-ray? From this X-ray, what do you find? From that you can say it's a chronic osteomyelitis.
Sir, Sir, there is some dark shadow in the bone.
Dark shadows. These dark shadows you mean.
Sir, yes, sir.
So what does dark shadows signify? Here there is dark shadows means there is loss of bone, but that is not something uh, specific to chronic osteomyelitis. Chronic osteomyelitis, you get some specific things in X-ray finding. So first you see, is this bone looking like radius, or it is something you are seeing it is very much broadened as compared to other.
Yes, sir, it is very broad.
Very broad. So in chronic osteomyelitis you find irregular broadening and thickening of bone. So you are getting here irregular broadening and thickening of this radius bone. So this one feature you can appreciate from this X-ray, that radius has been irregularly broadened and thickened. Okay. What else you are getting?
Sir, sequestrum.
Yes, you can see the sequestrum. This is the sequestrum, which is looking more white. So this is the sequestrum. As you can see, there is well-defined sequestrum formed within the bone. What else? So if you look at ulna, what do you see? Bone. Can you differentiate between cortex and medullary cavity in ulna? Can you differentiate?
Yes, sir.
This one at the center, which is looking slightly darker, that is medullary cavity. This, the one which is looking more white, which is more dense, you can say it is cortex. So in ulna you can clearly see this is cortex and this is medulla. But what happens when you see in radius? Can you see the cortex and medulla clearly? Can you see cortex, outer cortex, which should be hyperdense? Is it visible? No, it is not visible. So there is lots of corticomedullary differentiation. Okay. So that's what you are finding in here. You cannot distinguish clearly between cortex and medulla. Okay. So these are the some X-ray findings. Sometimes you will find when there is discharging sinus, you can find opening somewhere here or here or here, but opening you call it cloaca. So it is not visible in here. It is not visible, but sometimes you may find it. So what is the clinical features? What are the clinical factors of chronic osteomyelitis? Pathological fracture. In chronic osteomyelitis, fracture may happen or may not happen. Okay. So clinical features means what are the specific things which will occur or almost which you will find in this disease.
Sir,
So what
chronic discharging sinus.
chronic discharging sinus with bony spicules. So these words are very important. Only chronic discharging sinus is not specific to chronic osteomyelitis. In this discharge, you will find small bony spicules. So you can confirm that it is due to osteomyelitis. It is not due to any other abscess or any other thing. It is due to chronic osteomyelitis. Okay. What else? There will be irregular thickening and broadening. You can also appreciate from outside that the bone has irregularly thickened or broadened. The margins would be irregular, and you can palpate it from outside. What else?
Tenderness and discalculated.
tenderness on deep palpation. Okay, rest small things you can say. There will be tenderness, or there will be other things. There will be on and off phenomena, when there will be no discharging sinus, the pain will be greater. Likewise, you call it Wallenkamp phenomena. You get cyclic pain when the pus accumulates. It becomes more painful, but when the pus gets discharged, patient is comparatively relieved. So, what is sequestrum? So, how you describe sequestrum?
So sequestrum is
Sequestrum is a piece of dead bone surrounded by infected granulation tissue.
A piece of dead bone surrounded by infected granulation tissue. So, how does sequestrum feel if you hold sequestrum? How, whether it will be smooth, whether it will be rough?
So it looks pale, smooth inner surface and rough outer surface.
Why it is smooth? Why it is having smooth inner surface? Or why it is having rough outer surface?
The rough outer surface is because it is constantly coated by surrounding granulation tissue.
Okay, and it is smooth in inner side. So there is continuously formed pus. So the pus, usually due to accumulation of pus, the surface is smooth. So what will happen if we take out a sequestrum and we put it in water? Whether it will float, whether it will sink.
Sink.
Okay, why does it sink? There may be reason why it will sink. Something when it sinks in water, basic phase is that if it is denser than water, it will sink inside water. So why? The question is why it is more dense than normal bone. Due to calcification. Okay. What is the thing that does not happen, which makes it become heavy?
Remodeling of the bone.
Remodeling does not happen, or there is decreased reabsorption, or there is no decalcification. So when it is a continuous process, as you know, bone forming. Some things are deposited, some things are absorbed. So it's a process, ongoing process, absorption and reabsorption. So in a dead bone, the reabsorption does not happen, decreased reabsorption happens. So the bone becomes more heavy. Okay. So these are something about sequestrum. Types of sequestrum I taught you in theory classes. There are various types of sequestrums. Okay. So now we'll move to next section. So what is X-ray?
Sir, this is an X-ray of the knee joint in AP glue, where we can see the tibia, fibula, and the femur, where there is a supracondylar fracture of femur.
It says supracondylar humerus fracture. What is this line? There is a catching point for this. What do you say, whether it is a X-ray of a adult bone or whether it is a skeletally immature bone?
Sir, immature.
Okay, so it's radiograph X-ray of knee joint showing lower end of femur and upper end of tibia and femur with the not you can say of a person. So this is epiphysis and it is not used. So now
Yes.
epiphysis, you can see a shadow here. So that is not used. Now I think I have given you hint. So there is a fracture through the epiphysis. So what special type of fracture you say when there is fracture through epiphysis? You call it fracture. There is a classification for epiphyseal fracture.
Salter-Harris classification.
So which type? Right type? Salter-Harris. So which do you think there is fracture?
Above.
When the fracture line extends above to the type 2 Salter-Harris. Okay, so this is type 2 Salter-Harris. First you get when the fracture is through epiphysis, it is not displaced, you call it type 1. When the fracture line goes above, you call it type 2. When the fracture goes below towards the physis, you call it type 3. When the fracture crosses both above and below, you call it type 4. When the epiphysis is fully crushed, you call it type 5. So this is a classification for epiphyseal fracture usually in children. So now which loop is left? 125. So we'll make it fast. Anyone who can answer or anyone who wants to answer?
Sir, it is APU of the shoulder joint and it appears to be anterior dislocation of the humerus.
Okay. So this is anterior dislocation of shoulder. So critical point we can there is a lot about what are the other types of dislocation you find in shoulder? Posterior and inferior. There is a special name for inferior dislocation. What do you call it? Okay. So in anterior dislocation you get types of anterior dislocation. What are the types? types of anterior dislocation you get?
Sir, subclavicular, preglenoid, intrathoracic, and sir, one was a clavicular.
Subclavicular. So when this humeral head clavicle, you call it sub. You call it subcortical. When it is inside the thorax, you call it intrathoracic. So what is the most common nerve to be injured in shoulder dislocation?
Sir, axillary no.
Axillary. Okay. So in some methods, shoulder dislocation, use it. There are some maneuver. Coaches maneuver. What if
Hippocrates.
Hippocrates means it's just for historical importance. Nobody does Hippocrates nowadays. Coaches maneuver. What else? Stimson's gravity method. What else?
Traction contraction method.
Traction contraction.
Hippocrates method, technique.
Is there any other?
So Hippocratic technique.
I heard Hippocrates. Anything else? The
Traction contraction.
traction contraction method. Very good. There is a Indian doctor. An Indian doctor has found out a method or devised a method. Can anyone say that method called? It is just for your extra knowledge. Nobody is going to ask that. But at least sometimes we do by that method. It is very easy method. You can do it alone by making it over here. L Prakash method. Very good. So it's a very simple method. Sometimes we do when we don't have anesthesia available, so we can do it without anesthesia. Okay. So there are a lot many more things about shoulder dislocation. We will not go too into it, and we'll move to last and final. So this side, or what is this X-ray? So 125 to 126 to 150. Someone who wants to answer in this range, you can answer. Anyone? Any one of you can unmute and answer. What do you see in this X-ray? Make it quick.
Sir, actually it's going on, Tiga.
And first I said you have to describe the X-ray. It is a AP view showing tibia and fibula in both lateral view. And it's lower third of tibia, and there is also malunion in fibula. There is also malunion in fibula. Fibula is malunionated, you can see. Yeah, so what type of malunion do you think it is? Atrophic. So there are other types of non-union, hypertrophic, homotrophic, but this seems to atrophic as the ends have narrowed. So why not acute fracture? Why if I say is a fracture, acute fracture of tibia? Why do you say it is non-union?
Sir, there is narrowing in the fracture line.
The rim.
And there is
These ends, fracture ends, do they look sharp?
rounded edge of the bone.
Yes, these ends are not sharp. They have some red tip, but when you get in neck case get sharp ends, you can clearly get sharp edges, but here you get rounded edges, and you can clearly see the medullary cavity is obliterated here. Usually in acute cases we don't find those things. Secondly, you are finding here a malunion of fibula. You don't get that in first cases. Okay. So when do you say a bone to be in non-union? Means how much duration you need to?
9 months.
9 months. But in some cases we consider in 3 months also we can say non-union. So one of the example is which fracture we can say within 3 months or in 3 months that it is non-union.
Sir, head of femur.
No, it is not head, it is neck femur. Head of femur is different issue. So in neck femur fracture we can say it in 3 months that it has gone into non-union. So why lower end of tibia is one of the commonest site for non-union? There are many reasons for non-union, like soft tissue interposition, improper fixation, various other factors, but it is quite common in lower end of humerus, tibia. Why it is? So in lower end of tibia, someone wants to answer?
Lower end of the tibia.
Vascularity is less in lower end of tibia. Okay, there is muscle coverage is very less in lower end of tibia, as you can say.
Position of the tibia in the lower end.
Okay. Secondly, mainly the middle or left of tibia, it is supplied by posterior cortex is supplied by posterior tibial artery. This is posterior tibial artery they supply. It gets very much damaged during the fracture. So we usually get non-union. So what is the clinical feature of a non-union? Tenderness.
Abnormal gait.
Gait. Why? If I said what is the unifocal fracture of non-union, suppose it is in yours, then will you get abnormal gait?
Sir, abnormal mobility.
Abnormal mobility, you call it abnormal mobility.
Sir, persistent pain.
No, sir.
Persistent pain is not correct answer. Do you get pain? Is non-union painful? Non-union not painful.
Sir, no progress in bone healing.
My question is not that. My question is whether non-union is painful or a non-union is not painful. Suppose
It is
Painful on palpation.
there is nothing painful on palpation. It is tenderness. When you eat, you have to say it's not pain. You have to say tenderness. Tenderness on palpation. My question is non-union always painful or it is painless?
Sir, they usually feel pain at the side of the fracture.
Usually non-union is painless, but there are some conditions where you will get painful non-union. Now I will ask you what are the conditions in which you will get non-union. Usually most of the time, if you see clinically or if you find in OPDs, non-union they don't have pain. Pain it was usually it started when they had fresh fracture, they develop pain, then gradually the pain decreases, and in non-union in after 9 months or 1 year they won't have any pain. Most of the cases they won't complain about pain, they will only come with deformity or loss of transmitted movements, but pain is always is a thing. You won't find pain every time, but there are certain special conditions where non-union will be painful. What are those conditions? If there is soft tissue interposition between the non-union, So if a soft tissue interposition is the cause for this non-union, the soft tissue will always be in between those fragments. So they will keep rubbing it, keep irritating that soft tissue. So they always will have pain there. What else?
If there is infection for the damage.
Yes, if there is infection in infected non-unions, they are painful. Infected non-unions are painful. What else? Sometimes when in intra-articular non-unions, when they are nearer to the joint, you also get painful non-union. So these are some conditions where you will get painful non-unions. Otherwise, commonly the non-unions are not painful. But these are some of the conditions where you will get painful non-unions. Okay. So what else you may be asked in non-union? So various factors which lead to non-union, you all know what are those factors: personal factors, surgical factors, and factors related to fixation. So there are various. So these are some of the X-rays from each of the topic. So it was basically so that you will get used to, or you will become more familiar how the X-rays will come. Usually in table 5 you will have around 20 to 30 X-rays, and you will be asked few of them by the examiner. So henceforth, as we'll keep on covering theory chapters, we'll include those X-rays. Like we'll have tumor classes, then we'll have X-rays for tumors, then we'll X-ray, then other things also will come. Then gradually we'll also have sessions regarding implants and instruments, orthopedic instruments. They will also be asked in your table 5. There will be specimens asked. Okay, so there will be many more things. There will be bones, even like anatomy. There are asked questions. There will even be some bones. You will be asked about the bones, about that. So this is how your table vivas will be taken during your exam. Okay.